Okay. Good afternoon and welcome. I am Dr. Andy Schumann, the Chief of the Clinical Ethics Service at the Center for Bioethics and Social Sciences in Medicine here at the University of Michigan. It is a pleasure to welcome you to our bioethics grand rounds, and we are joined today by Dr. John Fortunato. Dr. Fortunato is an assistant professor. I almost promoted you of neurology at the University of Michigan. He's a new faculty member as of this year, who is a neuro-oncologist at the Rogel Cancer Center as well. He completed a neuro-oncology fellowship at Memorial Sloan Kettering Cancer Center in New York City and completed a neurology residency at the University of Chicago prior to that. He has a master's degree in bioethics from Case Western Reserve University and completed an ethics fellowship at the McLean Center for Clinical Ethics at the University of Chicago. He's interested in ethical issues in neuro-oncology, particularly related to prognostic information in patients with life-limiting cancers such as glioblastoma. It is my privilege and pleasure to turn the floor over to him. Please put Q&A and comments in under the webinar format, and we will address them at the end of the talk. Thank you so much.
All right, thanks, Dr. Schumann. This is the CME slide that I think I was supposed to have up during the introduction. So here's the code for everyone to get their CME, and also some news, it looks like, about some upcoming events. But it's an absolute pleasure to be giving this talk. Dr. Schumann said, I'm John Fortunato. I'm new faculty here, started in August, and I'm excited to be a part of the Michigan medicine team, and I'm excited to be a part of the ethics community here at Michigan. I don't have any disclosures. So a brief outline, so I'm a neuro-oncologist, and clinically, 100% of my clinical time is spent doing neuro-oncology and taking care of patients with brain tumors. I'm going to be talking about prognostic discussions with patients with glioblastoma, sort of as the template for the discussion today, because that's my area of expertise. But also talking about how that can lend itself to prognostic discussions for patients with other terminal cancers or terminal disease in general, but really focusing on terminal cancers and how we discuss prognosis in those difficult situations. We'll discuss the current guidelines from ASCO, the American Society of Clinical Oncology. They do have some guidelines on when and how we should be discussing prognosis with patients with terminal diseases and terminal cancers. I'm really going to be mapping out an argument for what I'm calling stage disclosure, and that's where we disclose some prognostic information right away, but I'm advocating for delayed disclosure of other prognostic information. And I think that's the area of controversy, and that's the area that requires some ethical analysis. And I'm going to make and put out a case before you as to why I think it's ethically permissible to delay some prognostic information and not discuss that with patients initially, particularly discussions of life expectancy, which can be some of the most sensitive prognostic information. The reasons why I think these can be delayed are really disease specific. So I'm going to use, as I said, GBM, glioblastoma, as a template, which is one of the diseases I treat most often. And because it's disease specific, I think that the recommendations really can be borrowed and lent to other cancers, but guidelines for each individual terminal cancer might be most appropriate. So I'll make that recommendation and lay that out why. Based on the ethical analysis we'll go through, I'll recommend revision of the ASCO guidelines with disease-specific considerations. So I didn't anticipate starting with talk about nocebo effect, but in preparation for this talk and reflecting on how I became interested in these things, I thought back to some projects I did earlier in my career that I really think set the stage for this interest. So I wanted to share that first because I think it sets the stage nicely. I'm not sure if other people have had this experience, but my experience has been when you tell folks that you have an interest in ethics, people really love to tell you the ethical issues that they've been thinking about. So that happened to me as a med student. I had done some work in academic ethics and did a master's in ethics before medical school. And I always wanted this to be part of my career. When I went to med school at Beaumont, not too far from here, and realized I wanted to be a neurologist and met with the neurologist at Beaumont. And when I told him I was interested in ethics, he said, well, let me tell you about this ethical issue that's been in the back of my mind. And he said, I feel like when I'm prescribing medicines to patients and I'm going through the side effect profile, I'm always anxious that I'm causing some of these side effects and making them more likely to happen when I'm disclosing these side effects. And so partially because this really interested me and partially because I was trying to be an impressive med student, I sort of grabbed this and decided to run with it and do some research on it. This is called the nocebo effect. So it's the inverse of placebo. Placebo is when we have positive expectations and they lead to positive outcomes. Placebo is a little more intuitive. We run placebo-controlled trials often. Nocebo is the inverse of that. So it's when negative expectations lead to negative outcomes. There's some, the most common place we see this is, or could expect this to happen, is medication side effects. There's some pretty good literature out there on nocebo effects having clinical relevance. First, there was a study back in the 80s using aspirin to treat chest pain. And they had, in this study, a 6-fold increase in patients that withdrew from the study for GI side effects. When that group was told, of the group that was told there would be a GI side effects, six-fold increase in patients that withdrew in that arm of the trial. Similarly, this study from 1990, I'm not sure what IRB approved it, but they took patients with food allergies and they told them that they had been injected with an allergen when they actually were just injected with saline. And 25% of those patients who were just injected with saline had experienced some allergic effects or side effects. Again, don't know what IRB approved that study, but was done in the late 80s, published in the 90s. This one, I think, is the most interesting, a study involving finasteride, which is used to treat BPH. Has a known side effect profile of erectile dysfunction. This study found that when there was a 3-fold increase in the incidence of erectile dysfunction when the side effect was disclosed up front. So from 15% to 44%. Essentially, what this is saying is, the doctor, in this case of disclosing the side effect, is almost twice as likely as the drug to cause erectile dysfunction, the disclosure in and of itself. So this work and looking into this, I partnered with an ethicist, Jason Wasserman, at Oakland University when I was there, with the neurologist, Dr. Menkes, and myself. We ended up putting together this ethics manuscript that we're really fortunate got published in the American Journal of Bioethics. And in this, we advocate for allowing for non-disclosure of non-threatening somatic symptoms. So if something could be life-threatening, of course you need to disclose it. And symptoms that cannot be somaticized, you probably should disclose. But things like headache, erectile dysfunction, we make the case that in some situations when there are minor side effects that are susceptible to the nocebo effect, it's okay to selectively non-disclose these side effects and follow up very closely, with the effort of with the argument being founded on that this would cause less harm to the patients and it would forestall autonomy. So the autonomy, and of course, this is quite a bit of an insult on autonomy, and that was the highest critique. The American Journal of Bioethics has response articles, and that was the largest critique, was that this was too much of a limitation of autonomy, which we do recognize and wrestle with. But we argue that it's justifiable by reducing harm and pushing the autonomy down the road and salvaging autonomy down the road in an effort to reduce side effects. So this was something that I had worked on earlier in my career, really before my career started. I was still a medical student, where and it's loosely related to what I'm going to talk about today. What I think is really impactful from this is that the physician-patient discussion, how you talk about your patients, really, you're not just conveying information and the information has an effect on the patients. The way we talk to our patients really plays an active role in their outcomes. It influences outcomes, and it has a role in the patient's quality of life, can affect symptoms. I think this sort of set the stage for how I approached my medical training, going into residency and fellowship, always thinking about how the way we talk to our patients is going to influence their treatment, is going to influence their outcomes. And for that reason, I became very interested in talking about prognosis. And I think there's a lot of parallels between the argument that I made in this manuscript, which was back in 2017, compared to the case that I'm going to be laying out today. So just a little bit of background there that I thought was somewhat relevant and interesting. Back to discussing prognosis. So what is prognostic information? Prognosis is one of those things that actually is hard to define. If you go through Beechup and Childress, they don't take the time to define it. It's already assumed. I think that we know what prognosis is. When I was a religion major in college, and they prompted us, this reminded me of that. They prompted us at that time to try to define religion. And they asked us to do that when we first declared the major, and then at the end, when we were finishing before graduating college. And it's always more difficult the more you know to define some of these simple terms. The most broad, this reminds me of that quite a bit. The prognosis is also difficult to define. In the broadest sense, it's really a forecast. It's a forecast of the disease and its prediction by the doctor, or by the provider on what's going to happen. Seinfeld has a good bit on the 5-day forecast, where he can deliver much better than I can. But he says, if the weatherman was right, we'd only need to hear from him every 5 days. Of course, we have the weather every day, and the 5-day forecast, 7-day forecast is often wrong. I think doctors have the same problem. We're notoriously bad. There's a whole body of literature out there on what a poor job we do at predicting prognoses and how long patients are going to live, and what the treatment course is going to look like, what the trajectory is going to look like. I think that difficulty that we have and how bad we know we are at predicting prognosis leads to a lot of the problems with prognostic discussions and a lot of the hesitancy on the part of the clinician. I know personally for me, my inability to be very accurate makes it difficult to predict prognoses for these patients. I think it's important to try to get granular on what components of information really constitute a prognosis, and develop this flow chart. And I think a good place to start, an important place to start, is whether or not a disease is curable, particularly with cancer, because the information is different based on whether things are curable or not. If things are curable, you talk about the projected clinical course, but you also really talk about the chances for a cure and the expected outcome, the likelihood of a cure, the likelihood of not a cure, the likelihood of control. It's a different conversation. When cancer is incurable, it's a different shift. You have a different conversation with the patient. You talk about the projected clinical course, but all treatment when in uncurable cancer is palliative. So there needs to be a discussion of life expectancy. Treatment might prolong life, but it doesn't cure the disease. I think really the ethical focus and the difficult things to discuss are the lack of curability and life expectancy. I think those are the two areas that are hard to discuss for clinicians and difficult to receive for patients, and that's really the sensitive information and the focus of this talk. Of note, I do think the chance for a cure and expected outcomes for non-curable or for curable cancers is also a difficult conversation to have. It's difficult to prognosticate and consolidate all the medical information, and I think that could be its own ethics talk of it all. But for the purposes of this talk, we're really focusing, I'll be focusing on uncurable cancer, the right side of the screen. And just to say here, really to sum that up, there's three components of prognostic information for terminal cancers. It's really the incurability, it's the projection of the life expectancy, and it's the expected clinical course. I would say the expected clinical course is something that's often discussed, even when prognostic discussions are avoided. Doctors are still talking about, here's the next steps in treatment, here's what we're going to do, here's how I think it's going to go, here's the side effects. So in terms of the ethical difficulty or the ethical analysis we're going to talk about today, I'm really focusing on the first two components of prognostic information, really incurability and life expectancy. I have this elephant that I've popped up and down the presentation here or there, and it's supposed to be symbolic of the elephant in the room. I think these things are difficult to discuss, they're avoided, and as I'll get to, there's a body of literature on this, but difficult for physicians to talk about, difficult for patients to receive. So let's start with why we discuss prognostic information. The primary reason is for patients to be informed and to be able to actively participate in informed consent for following treatment decisions. It's difficult to consent for treatment if you don't understand the likely outcomes and the things that are going to happen based on the treatment, or the things that will happen if you don't receive treatment. So the principles of informed consent are helpful to review. These pop up most probably on the ethics committee side when we're doing capacity assessments to go through these. But the first two elements are really the competence to understand and decide things, and then voluntariness, being willing to decide for yourself. And then there's 5 information elements: disclosure of material information. Patients need to be able to they need to understand the recommendation, understand the disclosed information, make a decision, and then authorize whatever they decide and say they understand the consequences of doing this or not doing this. Really, prognosis is material information, so it's very difficult to understand. It's part of the projected course without knowing that material information to make a decision. And consent's not entirely informed. So really, having the prognosis of your condition is essential to being able to exercise informed consent. Why do we need to disclose prognostic information immediately? The default is that we should tell patients everything right away, and that's what we're taught in medical school. And most of the time, 95, 99% of the time, that's really correct. Why do we disclose prognostic information right away? Well, the first reason is because it's the truth. And truth telling is is essential to our job. It's part of what we do. We don't lie to our patients, and telling the truth and giving them all the information so that they can make their own decisions is autonomy promoting. This is something that's central to the principles of bioethics, with autonomy being really the principle that ends up being prioritized most in American bioethics. Withholding information in these situations would be disingenuous. They can harm the patient. They can harm the doctor-patient relationship. And as I mentioned before, they would really, it would interfere with informed consent. You can't have truly informed consent if you don't understand the prognosis. Second point, I don't know why it says one twice. It should be the second point there. That's advanced care planning. So there's a body of literature really advocating that advanced care planning be done earlier in cancers, and for good reason. As cancer patients deteriorate and become more sick, it's more difficult to have conversations. They could lose their capacity to make decisions due to either, in the case of glioblastoma, local invasion of their brain that compromises their cognitive abilities, or from chemotherapies, toxic metabolic encephalopathies, other things that can cause inability to really participate in advanced care planning, making treatment decisions, setting up medical power of attorney. There's a big push throughout the cancer literature to really do advanced care planning as early as possible, particularly in terminal diseases. These are two very strong reasons to disclose prognostic information as soon as possible. There's a body of literature specifically in the glioblastoma world advocating for early prognostic disclosure for good reason. About half of patients with GBM have some cognitive defects at their diagnosis, and this is supported by the literature. We know that cognitive deficits can worsen throughout the disease course, and it rapidly worsens near the end of life. In the neuro-oncology literature, many have recommended early ACP for this reason, before the cognition worsens. And the price, timing, and delivery of this, though, is not really clear. The recommendations tend to be, we should do this early, but no one gets granular about how early, when do we do this? Is it at the first visit? Is it at recurrence? How early do we need to have the advanced care planning? Finally, it's not entirely clear what the trajectory of the cognitive decline is throughout the disease course in glioblastoma. We know that patients start with some cognitive decline, but often still have capacity to make medical decisions and do advanced care planning. And we know at the very end that patients rapidly lose that ability. We don't know if there's a steady decline throughout the disease course, or if cognition is maintained and then cognition sort of falls off the cliff. So the trajectory of how long cognitive abilities remain is not entirely clear in the literature. So I got a running scoreboard here, and I'm sort of keeping tally of arguments for early disclosure versus delayed disclosure. I told you I'd get into delayed disclosure, and I haven't yet. But mapping out thus far really the reasons why we should tell patients their prognoses as early as possible in terminal cancers. The first being it's the truth. The second being cognitive decline might be coming around the corner, more so for glioblastoma, but also for all terminal cancers due to treatments. And there's advantages to early advanced care planning to set things up so that the patient's wishes and treatment plans are respected. We'll get now sort of pivot and talk a little bit about reasons why it might be okay to delay some prognostic information. ASCO does have guidelines, and I want to mention the guidelines here. These were published in 2017, and they their overall guidelines for how we talk to patients. So they're not just about prognoses, but within that, they talk about how to deliver prognosis. The second sort of main recommendation on discussing goals of care and prognosis is listed here. There's really, they have good recommendations here. Need to provide prognostic information tailored to the patient. The clinician should assess the patient's goals, priorities, should provide information in very simply and direct terms. And when providing bad news, should take additional steps for the needs and responses of patients. So these are really talk about style and how to have the discussion when you're discussing it. And all of these are great recommendations backed by evidence, which they cite. There's no mention of the timing or the content of these prognostic discussions. And I think that's missing in the formal recommendation, which this is. Later in the manuscript, they do have a strategy section. So these aren't the formal recommendations, but these are strategies on how to do this. And this is specific about terminal illness. And they do recommend that within a month of diagnosis of a terminal cancer, that prognosis and advanced care planning be discussed. Again, they don't really specify what that prognostic disclosure consists of. What are the components of the prognosis that need to be discussed? They don't get granular with that, but the recommendation is here to have that discussion within a month. They recommend other things that are all related more so to advanced care planning and a surrogate decision maker, talking about advanced care planning and advanced directive, exploring goals and values. This work is citing two papers. It's really the first citation for this is just citing the Australian guidelines. So they just sort of said this is what all Australia's and New Zealand are recommending. So we're recommending it here. And then there's also a very nice 2014 JAMA review article that sort of gets into the nitty gritty of what's been done looking at patients' desires and wishes to know prognoses in terminal cancers. Despite these recommendations, I would say it's backed by evidence and also anecdotal experience that many doctors really avoid prognostic discussions. I would say some don't have them at all. In one large population-based study, prognosis was first discussed 33 days before death for metastatic lung and colorectal patients, just shockingly late. Physicians reported that even if patients with cancer requested survival estimates, they only provide a frank estimate 30% of the time. Other times, they provide no estimate, a conscious overestimate, or a conscious underestimate. I will say, to argue against this, these papers are a little old. This most recent one from 2021, the other one from 2012. That's not an excuse for it, but I think this level of paternalism is a little less emphasized in our medical culture today. So I would anticipate that doctors are better than these studies reveal, and oncologists are better than these studies reveal at discussing prognoses. But this is the literature from the early 2000s. This is a fascinating paper. This is a qualitative study. It was done by Alex Tate. She's a sociologist at the University of Chicago. I was fortunate to work with her on a few other unrelated projects in the neuro ICU as a neurology resident at University of Chicago. But this is a qualitative analysis that she conducted. So what she did was she had five oncologists participate in the study. 3 of them were gyn-oncs and 2 urologic oncologists. And she did video recorded their encounters with patients. So she had over 90 videos. I do think it's a little limited because it's only 5 oncologists, but it was 90 encounters, and she recorded the encounter in its entirety, transcribed it, and then did grounded theory qualitative analysis on the transcription to look at themes of how prognosis was discussed. Her findings were pretty striking. So, and I put the direct quotes here from the paper because I thought it was really meaningful. The most frequent way that physicians invoke death is in a persuasive context during treatment recommendation discussions. So when patients demonstrate active or passive resistance to a recommendation, that's when physicians invoke the possibility of a patient's death to push back against this resistance or lobby for treatment. Ultimately, this study concludes that physicians in these data invoke death to leverage their professional authority for a particular treatment outcome. So this is really strong language. She really cut to the chase here in how she put this. Ultimately, what she's saying is that, and I agree with this from an anecdotal perspective, that sometimes oncologists don't discuss prognosis up front. When patients are getting worse and we're moving on to 2nd or 3rd line therapies, and we say, okay, unfortunately your cancer grew, here's what I'd recommend now. Patients say, I don't know if I want to do that. And then that's when the oncologist says, okay, you don't have to do this, but if you don't get treatment, you're looking at 3 to 6 months to live. And it's not until that moment that those numbers are said, and that's, in a way, that's used as leverage to try to advocate for the treatment. If you don't do this treatment, this is how long you're going to live. Again, this was a really small study, 5 oncologists, but I don't think this is completely foreign with a lot of anecdotal experience of how prognosis can be discussed often in oncology. I want to talk about hope a little bit because, hope is one of the main reasons why a lot of oncologists don't want to discuss prognosis. They're scared that it's going to diminish the patient's hope or take hope away from the patient. They don't want to reduce the patient's hope for good reason, but they use that as an excuse or a reason to not discuss prognosis. Hope is another term, like prognosis, like religion that I mentioned earlier, sort of difficult to define. Throughout the social sciences literature, they do define it. They define it as the perceived capability to derive pathways to desired goals and to motivate oneself via agency thinking to use those pathways. So it's really goal-oriented is what hope, and it's about achieving possible goals and whether you have the ability to achieve certain goals and what those goals are. Many studies have found positive associations between hopefulness and physical and mental health. That's outside of the context of cancer, but just in general. amongst cancer patients, study from 2002 actually showed that higher dispositional hope, and dispositional hope is like inherent hopefulness, somebody who's a hopeful person, like a personality trait of having hopefulness, that was associated with actually longer overall survival in patients with advanced cancer. And this is the Kaplan-Meier curve here on the right, the line in green. I think you can see my cursor, but line in green here, patients with high hopefulness scores, line in blue, patients with less hopefulness, and overall survival in the bottom. So a better median overall survival for the patients who had hopefulness. Pretty surprising. Of course, this is correlative, not causative, but the correlation is there. And there's a body of literature talking about the moral obligation that we do have to preserve hope for our patients. And I think that that's pretty clear that there's no benefit from destroying hope. We want our patients to be hopeful. It's associated with well-being. As oncologists, we have a moral obligation to really preserve and foster hopefulness with patients. Many oncologists cite hopefulness, though, and our duty to preserve it as primary motive for withholding prognostic info. And there's a body of literature to show that. However, though physicians are anxious about this and are well-intended that they don't want to destroy hope, there's no evidence to support that prognostic discussions or disclosing a prognosis reduces patient hopefulness. Most patients still want prognostic information, even though even when it's poor, they want to know that information. And patients have said that in surveys. This is a paper from 2008 where patients were very clear they wanted prognostic information. This 2004 quote is from an opinion piece on this, but I thought it was powerful. Failure to disclose information honestly to patients might be an attempt for providers to protect their own emotional survival as much as to help protect the patient. And I think that could be true too. That's not based on evidence. This is somebody postulating, but I think that could be true as well. And we should acknowledge these are difficult for the provider to have. And for myself as a neuro-oncologist, when you're seeing these patients all day, it can be difficult when you're having these conversations back to back to back. And then, trying to go on and go home and see your family and live your life. So I do think there's a component here where oncologists might hold back. They could have had these conversations twice already in the day, and they're to the third time and they're a little burnt out, and that could contribute to the lack of these conversations. Hopefulness and after receiving prognostic information has actually been studied. This was a paper from 2010, a smaller study, enrolled 27 patients. They took the Hope Earth test, which is a validated tool to assess hopefulness. They gave these 27 patients with advanced cancer the hopefulness scale before the conversation. Then they saw their oncologist. They had a prognostic discussion that did detail life expectancy, and then they were given the survey after. This is the Hope scale. This is the Hope Earth scale. It's a tongue twister, but it's questions that really assess different components of hopefulness, having things to look forward to, having a sense of direction, feeling your life has value of worth. These are on a scale of 1 to 4, and then they're graded to a total score, with the highest score being more hopeful and a lower score being less hopeful. The pretest score for this was a 44, and it actually increased a little bit, not in a statistically significant way, but the punchline here is that hopefulness certainly didn't reduce. So the hopefulness scores before and after a prognostic discussion in these 27 patients were stable, giving some evidence that prognostic discussions do not diminish hope in this cohort. This was studied again in a much bigger group. This was in 2010. This was a more recent study. This is a 2022 study with 672 patients. So this trial was interesting. Also, the Hope Earth scale, same model, Hope Earth scale before and then 3 months after end of life discussion or a completion of an advanced directive when prognosis and life expectancy was discussed. All the patients in the study had advanced solid malignancies when they were enrolled. This was the screening to get into the study was actually by asking the oncologist. So oncologists were sent a survey, and they were asked to agree or not agree with the following statement: I would not be surprised if this patient died within the next year. If they said yes to that, the patient was eligible for the study, meaning that the oncologist estimated their life expectancy to be possibly a year or less. This was a large study, way bigger than the last one with 27 patients. This was 62 patients. And there was actually a statistically significant increase in the Hope Earth scores. So patients were actually more hopeful over the 3-month period than after receiving a prognostic discussion than they had been before. put together, this is two reasonable pieces of evidence that do not show any evidence that prognostic discussions lead to decreased hopefulness amongst patients with advanced cancer. This was a viewpoint piece from 2021 in JAMA. I thought this was really fantastic, fantastically worded and fantastically written. So I just wanted to share it, and it really details an approach of how to approach patients and how to really foster their hopes in these seemingly hopeless situations. And the quote here is really powerful. Rather than being concerned that hope is either so fragile that it can be lost, or so powerful that it can overwhelm decision-making of these patients, clinicians should remember that hope's protective, and that sort of normalizes it. It's protective because they're going through something so serious, and it's protective if not necessary for managing the serious illness. I thought this was really, really powerful. These protective mechanisms represent exactly what they are. There's hopes for the impossible future that patients wish they could have, that unfortunately they can't have. It really normalizes the hope. I think oncologists, we can get, and doctors and any provider can get so caught in the data and knowing that these patients don't have a long life to live, that we can wonder how they have hope and not want to touch it. But hope's very normal. Everyone has hopes. And this article tries to normalize this hope and say this is a completely normal thing and it's expected for patients to have these. It goes on to say that, hopes often are dynamic and changing, and they don't have to be logical. Patients can maintain a hope for a cure when recognizing that there is no evidence for a cure. In fact, as a field, we do that, right? We're studying, we're looking for cures for glioblastoma. There's labs all over the country that are investigating a cure, even though we don't have a cure now. So we have the same hopes that these patients do. One of the strategies that this article advises that I've tried to really bring into my own practice is this idea of holding hopes. And I thought this was interesting, and it's in the title, Holding Hope. And it's the idea that you kind of experience this hope with them and still disclose the prognostic information. And I've used this quote word for word, say, with what we know now, what else do you hope for? And you try to encourage patients to foster more hopes and what they term the coin as diversify their portfolio of hopes. And the hopes can change from a cure to other things that they want, being able to go play catch with their kid, being able to go on a bike ride. And as you expand that portfolio, as the oncologist or the provider, you can sort of grab onto those things that you find most realistic and work with the patient towards those goals. Not entirely relevant to the ethical analysis of when to disclose prognosis, but a really helpful strategy and I've really appreciated this article, so thought very relevant to discuss here. Back to our scoreboard. I detailed earlier the reasons to give early disclosure. They're still listed here. And I'm going to get now finally to the reasons why I think we can delay some prognostic disclosure in some situations. But I want to make a point. We discussed hopefulness. I think hopefulness is the number one reason why most providers don't disclose prognostic information, and it's actually not. It's not a good reason. It's not a good enough reason. We for the reasons we just discussed, we can maintain hope and disclose prognosis. There are some reasons to delay prognostic disclosure a little bit. Hope is not one of them. Let's get to those reasons why it's potentially okay, and I'll argue it's okay to delay prognostic disclosure of some information, really in the context of glioblastoma. And I think the context here matters. So I'm going to give a little overview of GBM. It's an incurable form of brain cancer. I'll do this quickly because this is an ethics talk, but incidence is 3.19 per 100,000 people in the US. About half of the malignant brain tumors we see are GBM. The median age is 65, so this affects an older population. And treatment consists of surgery, radiation, and chemotherapy. That's the upfront treatment. Later, patients sometimes can have more surgery, more radiation, and more chemotherapy at recurrence, depending on the situation. Using the most aggressive care and standard of care that we have, median overall survival is about 15 to 20 months. The median overall survival after recurrence, so once the tumor grows back, is about 8 or 9 months. And 5-year survival, unfortunately, is very poor. It's less than 5% of these patients are living more than 5 years. Some things that I think factor, I'll talk a little bit as an example, things that factor into prognostic discussions are molecular characterization of tumors. MGMT status is a molecular marker that we use to discuss tumors. And this slide's here to make the point that molecular diagnostics have really changed the way we think about the prognosis and have allowed us to be more accurate when we're prognosticating these tumors. There's endless research going into looking for different biomarkers, different prognostic, different things that we can find in the lab when we're analyzing these tumors that push the prognostic information one way or another, project a better or a worse prognosis. MGMT is the most classic one. We've known about this for quite a while, since really the standard of care treatment that hit the market in 2005. And really it signifies the responsiveness to chemotherapy. Just to illustrate how meaningful these markers can be, these are the different prognostic curves depending on what the marker is. Patients with a methylated MGMT promoter do better, and this is meaningful prognostic information. So tests like this really factor into how we discuss prognosis with these patients. Also, I want to lay out what our standard treatment is. Patients with glioblastoma get 6 weeks of, after surgery, get 6 weeks of radiation and chemotherapy. They get the radiation Monday through Friday for 6 weeks, chemotherapy the whole time. After that, they go to what's called the adjuvant phase, where they get chemotherapy once a month for 5 days. And this happens anywhere from 6 to sometimes 12 cycles. I really believe it's important to consider this context of what the treatment regimen is, as in terms of trying to find the best window to have a good prognostic discussion with the patient. That's why I mentioned the treatment schema. This is a broader diagram that I made, sort of mapping out when we see these patients. Each oncology visit I've labeled up here. So these patients usually get surgery. A few weeks later, 2 to 3 weeks later, they see their oncologist for the first time. And some of the path information is back, but everything is not back from the lab yet. Usually at this point, if it's a glioblastoma, we have a good idea. It's likely a glioblastoma or some other variation of an aggressive brain tumor that's going to require radiation and chemo. So we're able to know that by the first visit, I would say. This happens a couple of weeks after surgery. Then patients go and spend most of their time with the radiation oncologist. They get 6 weeks of the radiation while also receiving the chemotherapy. Usually we do a check-in halfway through the radiation to see how they're doing on the neuro-oncology side. This is sometimes done by the oncologist, sometimes done by a PA or an NP. And then they get a 4-week break after the radiation. They finish this block of radiation and then see their oncologist before starting cycle 1, the initial treatment here, where they start the first cycle of the chemotherapy that repeats itself. Again, that puts you about 14 weeks out from the diagnosis. I think that overall context is important to understand as I get to the recommendations. So the first reason, first counterpoint to early prognostic disclosure is information overload. That it's just too much information for patients to receive all at once. We know that recall amongst cancer patients is poor. Cancer patients forget 40 to 80%, depending on the study, of information given to them by providers. And this is tumor agnostic. This is all cancer patients. We would hypothesize that patients with CNS disease, with tumors in their brain, this could be even worse. This was a impressive study. Does age really matter on the recall of information? This was published in the Journal of Clinical Oncology in 2008, looking at 270 patients at their very first visit with a medical oncologist or a radiation oncologist. They had the visit, and then they had a follow-up phone interview where somebody called them and basically asked them to tell them what was discussed in the encounter, asked them questions. Was your prognosis discussed? What did you remember? What's the treatment plans? Questions about the encounter. And then their answers were cross-checked with an audio recording of the encounter. What they found was that the older patients recalled less, and that was dependent on the amount of info discussed. So the more, for older patients, the more information discussed in that initial visit, the less likely they were to recall it. In addition, patients with poorer prognosis recalled less, and the more prognosis discussed, the more time you spent on it, the less was actually recalled. So the more nitty-gritty we got about the nuances of prognosis, the less these patients were able to recall. For my clinical practice, seeing patients with GBM, they really check all of these boxes. Our median age of diagnosis is 65, so it's older patients. They have a poorer prognosis, so they're the group that's predisposed to recall less. And there's a lot of prognostic information to discuss. So the more prognosis we talk about, the less they'd be able to recall. So a little bit of evidence here that early prognostic discussions might not set in, might not be recalled by patients. This was also studied explicitly in the GBM population. So talking just to patients with high-grade glioma. This also includes mostly GBM, but also other patients with nearly the same prognosis. So a little broader context, but mostly consists of patients with GBM. This was a small study, looked at 19 patients and 21 caregivers, and asked a battery of prompts via a semi-structured interview and using grounded theory and qualitative analysis to try to then parse out themes and see what patients remembered or could recall about their prognostic discussions that they had with their oncologist. The questions they were asked were: what information about prognosis was provided? Was it helpful? Why not? Do you feel you were told the right information, too much or too little? How was the timing? And how much did this help you? How much did it help you understand? A few themes emerged. The first was shock at hearing the diagnosis. Every single patient and every single caregiver reported shock at hearing the diagnosis alone. So just the diagnostic information. Second, they also reported a great deal of difficulty trying to understand and process prognostic information while they were still experiencing that shock from the initial conversation. Other things that we'll get to, I mentioned earlier that hope does not get decreased after a prognostic discussion. This paper actually argues against that, and we'll get into the nitty-gritty on that. Patients expressed desire for individualized prognostic information, and they also expressed a little bit of discomfort with the clinician's communication skills. They thought they could have been better. But focusing here on the shock up front, I want to give a few of the excerpts from the transcript. This was from a caregiver who reported she just wasn't quite ready to hear the timeline. She said, "So you can imagine, I got 3 little kids. We're not from the city. We're from the country. 4 days into this, the doctor calls me on my phone, and they already told us we're getting results in a few days. So for the doctor to call me when we were still in recovery and say it's a high-grade cancerous tumor," I said, "What does that mean?" And he said he probably has between 4 to 9 months to live. I was outside recovery. I just slid down the wall in that hospital. So a real good characterization of a caregiver who wasn't quite ready to hear that life expectancy estimation from a provider. And this was a theme throughout. The majority of participants interviewed spoke to difficulty in trying to take in and make sense of this prognostic information when they're still in shock from receiving the diagnosis. Some patients couldn't recall the details on the diagnosis or the prognosis, and they believed they had not been given complete information, or they just said, "I don't want to hear anymore," because they were a little overwhelmed. I heard another talk on this that was by Alex Porter, who's a neuro-oncologist at Mayo, Arizona, and she called this the action potential of emotion, which I thought was a great analogy to what happens, but analogous to action potentials that we learn about in medical school. When a neuron fires, and then there's a refractory period where the neuron cannot fire any longer after it reached that critical threshold and fired. And there's nothing, no matter how much information or positive or negative charges come in and out of cells, the neuron can no longer fire. It's really an analogy here where there's a threshold of information that patients can process, and that shock hits, and they're unable to process any further information. I don't think that action potential of emotion is a coined or published term. I didn't include it in the presentation, but I think it's really interesting. And I think anecdotally we see that with patients, and there is data to suggest that patients need information little by little. Go back a few slides. The third point down here says that these patients had the perception that hope was being taken away. And this goes directly against what I had discussed earlier, that prognostic discussions don't take away hope. So I thought it was important to address this kind of head on. Here are the quotes from this. So two excerpts of patients who felt their hope was being taken away, or caregivers who said this. And they said, "One day we have a family meeting with some doctor, and she overlooked her glasses and looked at us and said, 'There's no hope.'" Another quote was, "The doctor called me away from the bedside and said, 'Do you realize this is hopeless?'" So it's not necessarily the prognostic information here that decreased the patient's hope. In these situations, the patients were explicitly told by the doctor, there is no hope. So I think that's a difference. And it really highlights the value of qualitative studies, because you really get this level of detail, even though the sample sizes are small. Again, just reemphasizing, it's really our job as clinicians to try, what we're balancing here is trying to preserve hope and have these prognostic discussions at the same time. we should not be saying to patients we should not be telling them there is no hope. Certainly, if you tell them there's no hope, we would expect their level of hopefulness to come down. And that seems to be what happened in this study. To be fully, these were a few examples. It was a qualitative analysis, and they didn't put every transcription from every patient, but at least in these examples, the physician or provider explicitly took hope away and told them there was. Some other works that's been done with GBM. This was a paper from 2022 that came out of Sloan Kettering. It was a multi-site study. It was looking at how patients cope with glioblastoma. Was the broader study, and there was a lot of research forms and surveys that patients filled out. A subset of that was interviews that were done with the triad, meaning the provider, the caregiver, and the patient, all three of them filling out surveys after a prognostic discussion. So the way the study was set up was that following a visit, the study team would ask the neuro-oncology team, hey, did any of your patients progress today? Meaning, did any of them have a worsening MRI scan and they need to move on to the next course of treatment? And if they had progressed, they were followed, the oncologist did a survey, and the patients filled out surveys. And the survey consisted of questions about their understanding of prognosis and just whether or not it was discussed or not. Findings were pretty striking here. There was no concordance in response, or meaning there was no agreement between the oncologist and the patient or caregiver as to, particularly between the caregiver, between the patient and the oncologist as to whether or not prognosis was discussed. 3 patients reported having discussed prognosis, while 10 oncologists said they discussed prognosis. The caregivers were a little closer. 8 caregivers agreed with the oncologist that the prognosis was discussed. There was also disagreement on whether or not prognosis had ever been discussed. 7 patients said it had never been discussed, where 13 oncologists said, yeah, we discussed this before, but we just didn't discuss it today. So a disagreement there. Looking at these triads, the triad of the three people who filled out the survey, the oncologist, the caregiver, and the provider, very limited agreement. They showed limited concordant responses in discussing curability. Only 5 times did they discuss whether that had been discussed. Prognosis in general, 4 times. End of life treatment, 4 times. Or ever discussing prognosis. There was only agreement on whether that happened 3 times. So this paper does not really ask the questions: when should we be discussing prognosis? How should we be discussing prognosis? What's the right way to do this? This study is just looking at whether patients or caregivers or oncologists agree on whether these things were done at all. And there's no agreement in hindsight as to whether these things were discussed, which really suggests the poor recall in these situations. This is really my hypothesis and my anecdote here, but I think we're discussing these estimations of life expectancy at the wrong time. It's really convention that these are discussed at the time of treatment decisions, when there's a lot of other things to be discussed, particularly if it's not done up front, which often it's not. Prognostic discussions are sort of, the can is kicked down the road until cancer gets worse and it grows back. Like that, the study we just went over was set up to assess whether or not prognostic discussions happened at the time of recurrence, but they've received a lot of information during that visit. They've heard about the treatment they're going to receive, that they've been given the news that their cancer is growing and returning. They're just pivoting right to discussing treatments and what the next steps are, so we can jump on this right away. And I really think these estimates of life expectancy are buried in a broader conversation about treatment logistics. This is a ton of information for patients, and I think it can be quite overwhelming. And we need to find a better way to have these discussions and really isolate time to have a prognostic discussion with these patients. Back to our scoreboard. That's my case for information overload as to one reason why I think we can delay prognostic discussions. I'll move a little quicker here because we're running out of time. Relationship building is another reason. Patients that trust their doctors are more likely to be satisfied with their physician's communication, and cancer patients are more likely to be adherent to treatment recommendations when they trust their oncologist. Anecdotally, a lot of second opinions at tertiary cancer centers, patients who come here for second opinions. When I was in fellowship in New York, patients who come from all over, the Northeast or all over the world to get second opinions there. Often the reason they're coming there is because they were in post-op, or they were in their first oncology visit with somebody they'd never met before, and they didn't like the way the information was conveyed to them. They thought it was too harsh, and they wanted to get a second opinion because they thought that provider was not going to be a partner with them and going to be on their team. Building the relationship can only help. And I really want to, again, look at the schema here of when we see patients. Patients have surgery here. and then see the oncologist a few weeks later, and then see us several times within the next few months. So there's several follow-up visits that follow oncology visit 2 and 3. Might be times when some of the prognostic discussion could be had. Back to the scoreboard, I think building the doctor-patient relationship is kind of the second point that could be really important for helping us really justify delaying some prognostic information. Finally, the third is a logistical consideration that's important, not really an ethical issue, but it's part of the treatment landscape and part of the logistic, is that as oncology has switched to molecular diagnostics, a lot of the pathology results we get are delayed. So we get an initial histo read from the pathologist who looks at it under the microscope and can give us an idea what these tumors are. But basic immunohistochemistry tests that we use to prognosticate can take up to a week. MGMT methylation, which I show the differences in the prognostic curves here, can take weeks, depending on the institution. I will say University of Michigan is very fast at getting these tests, faster than I was used to in fellowship. So I often have this information at the first visit. But I would say across the country, many places don't have this information at the first visit. Next generation sequencing, which is recommended for all cancers and has a tumor agnostic recommendation to look for genetic mistakes in these tumors, can take up to a month. Ours at the University of Michigan, we send out to an outside company that runs this testing. So that takes time and is often not back at the first visit. Methylation profiling, which we do quite a bit here, also helps us identify tumors, understand what they are, and can help with prognosis. That can take up to or over a month. So there's a lot of information that when we look at the initial schema here, you don't have at your first visit. And that information is prognostic. And if we're going to be accurate with how we deliver prognosis, we could wait for that information to increase accuracy. So really, I think a few different reasons here for delayed disclosure of this information. This is another slide. It really doesn't portray anything other than the last slide, but I did spend a lot of time on it, and I like the weighing of the scales, and it articulates how I think of things. And so I included it. Here's really the recommendation based on everything that we just went through of what I would recommend and the case that I'm making for the disease that I treat, for glioblastoma. I think at the first visit, we can have a discussion and mention the incurability of glioblastoma. They've been told their diagnosis already. So the diagnosis has already been delivered. And one of the really important and essential parts for understanding the treatment that we offer that's palliative and is not going to lead to a cure is understanding that we don't have a potential cure. I don't think this information can be delayed or skipped. And I think it's very important to set the framing and the tempo for the treatment as palliative throughout the course. That being said, this is still, it's devastating news to hear that you have an incurable cancer. And I really think that's enough for the reasons we discussed in information overload. That's enough of a discussion there. And the discussion of life expectancy can be pushed down the road. Oncology visit 2 is a time where you could have that visit. Often that's not a physician visit. And I think oncology visit 3 is really a great time to have that discussion. There's a few other logistical reasons why, in the context of GBM, that's important, is because, or appropriate oncology visit number 3. And the reason is because we almost never change treatments there. So there's not much else to talk about. We get an MRI after radiation. That MRI is sometimes worse, and it's because of the radiation that it's worse, where the treatment plan's been set. It's been discussed at least twice with the patient. They know their diagnosis. They know it's incurable. There's nothing else to discuss here except starting treatment. Given the logistics of the landscape of the current standard of care, this is really a window or a pocket opportunity where there's not much else to discuss, and we can dedicate the time to having a life expectancy discussion and advanced care planning. So in this way, I'm advocating for a 2-part approach where we discuss incurability first and delay the discussions of life expectancy till later. A really, really important thing here, and it surprised me before I started fellowship, and it might surprise you. Patients often don't ask. And I think a common question here is, well, if they ask for it, what do you do? Of course, if patients ask for prognostic information and they explicitly ask for an estimation of life expectancy earlier, you have to answer them and give them that answer honestly. My own clinical practice is that what I tend to say is, we can discuss that now if you'd like, but are you sure you're ready to hear that information? And I have had a lot of patients say, yeah, you're right, maybe let's just wait. And they recognize that they're maybe not ready to hear that. And I tell them it's okay to wait, or I'm willing to have that conversation early. I do think if they ask, we have to tell them the truth, and we have to give them the information if they ask. Surprisingly, a lot of patients don't. I think it's the norm that patients do not ask for prognostic information. Um, I'll also share that anecdotally, I think that is changing a little bit. My opinion on that's changing as I've switched to University of Michigan as a new provider here. I think in New York, where it was tertiary referrals of patients who want to be hyper aggressive for their cancer and are flying all over the country, they might be a phenotype that's a little less likely to ask. So that's sort of my anecdote here. See, we're running towards the end. Advantage of delaying the disclosure of life discussions of life expectancy are what we've discussed. The provider and patient relationship is more established. You know the person that you're giving this information to, and you can tailor it to them personally a little more. As I discussed, there's rarely other news at this visit, at the third visit, which mitigates the risk of information overload, and you're going to have the final pathology at that time, so you're allowed to you can be a little more accurate. I think the tough ethical question here is, what are we risking by doing this? And I think whenever you're balancing ethical obligations, you have to be honest with yourself about what you're sacrificing. And I want to be honest here that we're sacrificing some truth telling. It is untruthful, and in the strictest sense, it does decrease some autonomy to withhold non-prognostic information, even temporarily. It's not that you're lying to the patient, but you are omitting it, and it does count. I'm Catholic, so maybe the sins of omission are a big thing in the Catholic Church. Maybe this is my Catholic guilt coming through, but I do think it's important that we're honest, that we are sacrificing a little bit of truth telling to do this. The idea being that you're not sacrificing it much, you're always willing to tell the truth, and there's benefit, which we went through. There's also argument that you're delaying advanced care planning and cognitive decline. You could lose the window to have advanced care conversations due to cognitive decline. I think it's really unclear if that's clinically significant. And I get to that in this slide. I'm not sure if this would be harmful to patients. I don't think it is. Life expectancy, we're talking about a 3-month delay in life expectancy discussions. Here's the overall survival curve for patients, and you can see that within the first 3 months, radiation is the most effective treatment that we have for these tumors. Most patients do not progress or get worse during radiation. And you can see that reflected in the curve here, that survival doesn't start to dip until we get to about the 6-month mark, and then this slope steepens. Very few patients progress during radiation. And also for the patients who do progress, it does happen. Had you discussed estimations of life expectancy at diagnosis and told them they were going to live 18 months, that also would have been incorrect. So you would have been giving them an incorrectly optimistic estimation of their life expectancy had you given that prognostic information earlier. In addition, much of the advanced care planning can be completed without explicitly discussing the numbers of the life expectancy. You discuss that things are incurable and that treatment is palliative, and you can do advanced care planning with that information. I think there's a lot of special situations here that often arise. These aren't super unique to neuro-oncology or to oncology in general. So I don't think they're super relevant for the discussion here, but patients with there's situations of patients with extreme distress and therapeutic privilege. There's patients who request no prognostic information and want nothing to do with any of the information for the entirety of their treatment. There's patients who request all prognostic information. You get the engineering analytical types who want to get into the data with you. And I think following their lead and respecting their autonomy in all of these situations is appropriate. Nothing specific to oncology here, but these issues arise in clinical practice. There are patients with medical comorbidities and patients that you can predict as an oncologist due to their functional status are going to do particularly poor. I think that is the situation where this stage disclosure doesn't work as well, and you might be more inclined to do an estimation of life expectancy earlier than later. So to wrap this up, I'm advocating for a stage disclosure approach for the delivery of prognostic information for patients with terminal cancer, and particularly patients with glioblastoma. And I think this balances the ethical obligations that we have to our patients. ASCO recommends discussions to be had within 1 month. I think that's a little early, actually, and for the reasons that we discussed. I think these are too stringent. And if they're too stringent for GBM, which is really one of the most aggressive cancers, they might be too stringent for other cancers as well. I'd really recommend disease-specific factors that can be considered. As you can see, as I went through this talk, a lot of the rationale for these recommendations are based on specific details about the treatment plans for GBM and are unique to GBM patients. I think that recommendations moving forward would be most appropriate coming from subspecialty oncology organizations talking about their specific disease and how to best frame a prognostic discussion in the framework of their disease. Finally, I think you could make a case that there's literature out there that hope doesn't get destroyed in cancer patients when they get prognostic information. You could wonder if that really is true with GBM, one of the most devastating diagnoses. I think it'd be interesting to study that specifically in the GBM patient population, idea for a future study. I want to say thanks to some of my mentors from fellowship at Memorial Sloan Kettering, Eli Diamond and Amy Scharf. I have a accompanying manuscript that I'm revising, hoping to submit within the next few months. It's basically this talk, making this case. And I want to say thank you to our patients.
Dr. Fortunato, that was really a masterclass in how to take data and clinical experience and put it in an ethical framework in ways that really resonated. So thank you. We are over time. There's a bunch of questions, and frankly, I have a ton myself, but we're over time. So perhaps we will invite you back for more of a discussion and roundtable. But for now, I will simply thank you for sharing your wisdom with us, and I wish everyone else a good afternoon.
Thanks so much. I will say, please feel free to email me. As I mentioned, I'm working on a paper on this, and I think any critiques are very strongly welcomed and will only strengthen the paper. It took me a long, I was writing this on and off throughout fellowship, and the reason it took me so long to write it was because I kept changing my opinion as I learned more. So appreciate any feedback.
Appreciate you. Thank you.
Thanks.